Thank you everyone for joining our very first pop-up. Again, this is a live presentation series that our EI and WI system has begun presenting to everyone. It will be exactly as it's named. It will be a pop-up as topics come to us, and we feel like it would be a good conversation to have with the Birth to Three program workforce. We will be hosting these pop-ups. Our first inaugural event is about tongue tie, and we have an expert here with us to share. A few first ground rules or things to know about our pop-ups is that, again, we will be recording and sharing the first part where our presenter will be sharing information, and then we will have a time for discussion. Especially in this beginning, just to cut down on background noise with our recording. If people could please mute themselves, and if you need to turn off your video, that would be fine during this part. As we move into the Q&A session, though, we would love it if you would unmute, or mic up and share your screen and interact with our presenter. We do ask that if you have any questions that you'd like to pose in the session, kind of hold those until the Q&A session, unless it's something you just need clarification on in the moment, or if you're having trouble accessing the information, and then just put those in the chat and we'll respond to those as we go. There will be a few opportunities to also interact during the presenting time in the chat. And then just a little caveat, we have invited our speaker to come today. We've done a run through with her. We think her information is wonderful, but just a caveat, if there's anything that comes up, we don't necessarily agree or disagree with the information that's shared in these presentations. So without further ado, I'm going to introduce our speaker, Cindy Lund. She is an associate professor at Concordia here in Wisconsin, and she works in the speech and language pathology department. And she's also the president of the Wisconsin Speech Language Pathology and Audiology Association. So an expert in all things speech therapy. Give you that kudos, Cindy. So I'm going to stop sharing my screen. We'll just have a brief pause as Cindy pulls up her slides. Thank you.
Okay, thank you. Let me make sure I've got the right screen. There we go. Okay, thank you so much. I really am very grateful for the invitation. I think this is a really exciting idea of doing these pop-ups. I think it's going to be really valuable to all the providers and things like that. So truth about tongue tie, myths and evidence. There's a lot of things out there, lots of questions people have in terms of what is tongue tie, what is it not? So first, just because I am, now I've got to make sure I've got the right, is it not changing the slides? Oh, there we go. Got it. Did it change the slide?
It looks good on our end, Cindy.
Okay. Okay, just because I have been trained well by ASHA, I've got my disclosures here. I do receive a salary from Ascension Healthcare and Concordia, which I very much appreciate. And non-financial disclosures, I am the current president of WISHA and also am part of the Feeding Matters Wisconsin Community Council. This session is going to provide kind of a foundational basis for understanding tethered oral tissues and the impact on their function. Really looking at a review of kind of relevant anatomy and physiology and how the needs for how that impacts functional speech and feeding. So don't worry, we're not going to actually do an icebreaker. I just thought this was a funny meme. But it is nice to know who's here. So if you can put in the chat what your discipline is, OT, PT, speech, parent, educator, and we'll just take a little minute here to know who's with us.
Hopefully you can see that, Cindy. We have a pretty mixed group, it looks like, so that's
Yes,
exciting.
it does look like that. That's great. Good. And I think that's such a great thing to have all our different disciplines represented, because everybody's in the home and I'm sure everybody's getting the questions from the parents. So, um, all right. So now when you hear the term tongue tie, what do you think of? What does that bring up, whether it's a definition or feeling or what? If you can put that in the chat now, let's see what tongue tie really brings up for us. Feeding problems. Yeah. Controversy. Absolutely. And I am definitely probably going to add to the controversy. Feeding difficulties, language delay, tongue restriction. What do I do? That's great. Um, so yeah, less tongue mobility. Absolutely. Great. So just to kind of make sure we're all on the same page with our definitions, ankyloglossia is the medical term for tongue tie itself. And basically breaking it down, ankylo meaning constricted or stiff in movement, and glossia is anything referring to the tongue. Prevalence, there is definitely a disparity between increasing trends, demographic and socioeconomic differences, and available evidence is emphasizing the need for more objective diagnostic measures and high quality studies of the impact of ankyloglossia on infant feeding and speech development. So there is an overall prevalence at about a year of age in less than a year of age of 8%. However, what we do see here, these are not typos, but there has been an 834% increase in the diagnosis of ankyloglossia from 1997 to 2012. We don't have all the updated numbers from there, but I'm imagining it's continuing to grow. Frenulum procedures, there's an 866% increase in the procedures. That to me is a striking increase in the incidence and the prevalence. We do know that it's more common in males, but a couple of the other questionable, concerning things are that it is also found to be a much more common diagnosis and procedure in people who have private insurance versus Medicaid, as well as people in mid to high median income zip codes. There's a higher diagnosis. So there's a concern here of, is there an overdiagnosis or is there an overtreatment? We really want to look at this more closely to be sure that we are diagnosing it appropriately and that kids aren't being harmed by potential interventions. So here looking at some of the trends, Walsh and colleagues found a significant difference in the diagnosis based on payer status. As I said, there's an increasing discrepancy starting in the early 2000s with a much more common diagnosis of ankyloglossia in those with private insurance. So why is that? I've got my own suspicions. I'm sure many of you do too. But we'll look at some of the other trends as well. So we also have a significant rise in the incidence of diagnosis and surgical management starting in 2012. So right about where that red line is, we have increase. So the question there again is why? What happened in 2010, 2012, those years? We don't really have enough data yet to help us decipher why the increase, but there are definitely suspicions. And the fact that it is often seen more in higher payer status areas definitely is concerning. So looking at Google Trends, looking at just what is the interest of it. So you can see on this graphic that Starting around 2010 again, Google searches of tongue tie have been on the rise and significantly on the rise in the last 5 to 10 years. Um, my guess is that those early trends of that rise have to do with just internet access and people having more access to it. But why is it continuing to rise? Why is it such a hot topic? And then lastly, Google Trends, we look by region. There's the blue areas, the blue shaded areas are the ones that have the highest interest with people doing Google searches. And you can see that the majority of these are first world countries. So it is definitely something that is a moneymaker. The top 5 searches or regions are Zambia, Ireland, Australia, United Kingdom, and New Zealand. Zambia threw me off a little bit, so I did a little bit more digging on that. And there has been a strong focus and a push in encouraging breastfeeding support and breastfeeding in Zambia. So I think that might have something to do with why Zambia is on that list. So the oral cavity, is the entry point to the digestive system and plays a crucial role in digestion, speech, and respiration. Its anatomy has several components, each with distinct functions. So we'll look at a brief overview of the anatomy of the lips, the tongue, the hard palate, soft palate, and the buccal tissues to help us understand the impact of that lingual frenulum better. Oops, there we go. So looking at the lips here, we have the structure is soft tissue covered by skin on the outside with a mucosal membrane. And the functions are for speech, facial expression, which is also has a lot of cultural components to it, as well as holding food in the mouth during chewing and forming a seal during breathing and drinking, especially that's very important when we're thinking about extracting liquid from a breast or a nipple, that they have to be able to get lip closure around there to help form that seal. The suck itself is primarily coming from the tongue. The lips are sort of along for the ride when it comes to breastfeeding and bottle feeding in those early stages. And then we'll look at the tongue. So the tongue is got several surfaces and it's much bigger than we really think it is. We really only can see about 1/3 of our tongue visibly. So it occupies the whole floor of the mouth. And if you can see my cursor, hopefully, this outlines the tongue and it goes all the way down to the floor of the mouth and into the pharynx. So it is a much bigger structure than, than than most people think. So we can break it down into its surfaces. We have the dorsal tongue, which is that superior surface along the top. The ventral tongue is that inferior surface. And then the posterior tongue coming back here up to the foramen, as well as then the tongue base. The tongue base is where the posterior tongue meets the epiglottis. So here's our epiglottis, and then our vallecula is that space between the base of the tongue and the epiglottis. The tongue base is really this area down here, inferior to the foramen. So that's important when we start to think about posterior tongue tie versus anterior tongue tie. The tongue itself is going to be very dependent on its own musculature, intrinsic and extrinsic muscles. So the intrinsic muscles, which we'll look at here, are the muscles that are responsible for the fine shaping of the tongue. And that's really important when we think about sucking and swallowing, as well as articulation. So being able to cup your tongue, being able to lateralize your tongue, being able to flatten, those are all components that are coming from the intrinsic muscles of the tongue. So we have 4 main intrinsic muscles of the tongue. We have the superior longitudinal, and that is this pink line here. And that is responsible in isolation for elevating the tongue tip. The inferior longitudinal is really helping pull that tongue tip or the anterior portion of the tongue down. The transverse muscles are represented here by this green dot, but I have a better view on the next slide. to look at that one. And that is really going across the tongue. So the transverse muscle is there to help narrow the tongue, which is important when they're cupping and trying to get that shape and grasp around the nipple. The vertical tongue muscles then are there to help flatten. Again, really important when we think about them working all in synergy to be able to cup and extract, as well as to be able to get very specific points of constriction for articulation. So here's a better view. When we think of the vertical muscles, the vertical are really these that are going up and down here. And they help with flattening the tongue. There's our superior longitudinal and then our inferior. And then this other view here shows our transverse, where it's really the muscle is coming across the width of the tongue. And that's where we know when it contracts, it's helping us with narrowing the tongue itself. The extrinsic muscles then are responsible for the bigger movements of the tongue. So the intrinsic are the shaping, the extrinsic muscles are those that are there for those bigger movements. And just a few of the key muscles that we should be aware of here are the genioglossus. And that is this one, it's the biggest one down here. And that is the prime mover of the tongue. So it's not involved in every movement of the tongue, but it's involved in quite a few of them. The hyoglossus is here on the lateral side. So that helps with pulling the sides of the tongue down as it contracts, pulls it down. Styloglossus is going to help with pulling the tongue up and back. So here's our styloglossus here. It kind of looks like a sling up this way. And then palatoglossus. Palatoglossus is that posterior faucial pillar, and it is going to help with elevating the back of the tongue. So this is just another view of those, but I wanted to point this out because as we think about where the frenulum is really coming from the inferior surface here of the tongue. So we'll talk about it a little bit further, but it used to be thought of that it was actually embedded into the or the genioglossus, and that is something that we have now found to not be true. So as we look at what are these structures we're talking about, the lingual frenulum and the labial frenulum. So the lingual frenulum is this tissue right here from just under the tip of the tongue down actually into the surface of the mandible, not into the genioglossus as was once thought. And then our labial frenulum, so if you ever think about a lip tie, that is coming from the inside of the upper lip onto that upper gum. So a couple of common tethered tissues that we think about. So tethered oral tissues is really looking at that group in a whole. We're going to focus primarily on the tongue tie, the ankyloglossia, but there are also lip ties and buccal ties. The lip ties are when that labial frenulum here is too short. That does not have much of an impact on speech production unless it's impacting the full mobility of the upper lip. However, you will oftentimes have orthodontists or dentists who need to clip that in order to work on orthodontics. So if that labial frenulum comes and it's actually attaching further down in the gum and between those upper teeth, they may have to clip that in order to get braces to actually work and close the space. But it doesn't have an impact on speech production. And that's something that I think is important for families to know, that it may be something necessary for other functional reasons besides speech and feeding. Buccal tie is when we're talking about those cheek pockets where some of the buccal tissue in the cheeks is actually tethered down to the lateral gums on the lower side typically. But we're not going to address those too much today. So what is the lingual frenulum? So Mills and colleagues had described the anatomy of the lingual frenulum and the relationship to the floor of the mouth through a series of fresh tissue microdissections that they did. And what they found was that it's a diaphragm-like structure that suspends the tongue and the floor of the mouth within that arc of the mandible. So not into the genioglossus as we used to think, but actually right into the mandible, that lower portion of our jaw. And that gives us a lot more support and balance between mobility and stability. And that's really important as we think forward. Sometimes when kids are having their lingual frenulum clipped, it might give them more mobility, but they may lose stability, which can lead to respiratory issues, or if they have, especially kids with lower tone, they can have more issues with their tongue falling down into their airway. And that is quite problematic. So essentially, it's a three-dimensional structure that really varies on a spectrum. And it's formed by a sheet of fascia rather than a band of midline fibers, which is what used to be the thought. So, like I said, that facial or a fascia sling rather than the band of midline tissues, connective tissues. It is a basket weave orientation across that crosses midline. Um, and this is pretty consistent with what was found back in the 60s. Then we kind of stepped away from it. And now we've kind of found that, yes, it actually is this band. It inserts to the mandible, not the tongue base. Therefore, there is question about doing any kind of deeper frenectomy or clipping because we are completely disconnecting it from the tongue muscles, those extrinsic muscles. There are nerve fibers found around the surface of the ventral tongue, and so that can impact sensation and kids' ability to feel, excuse me, feel food in their mouth and be able to control that. And though that frenectomy or frenulotomy may free up mobility, it can make stability worse, and that's what I was talking about in terms of concerns with respiration, and this is especially impactful for kids who have lower tone. So just briefly, I'm going to touch on posterior tongue tie because I know it is a big topic as well, but that seems like it's a whole nother presentation in and of itself. But the question is, what is a posterior tongue tie? And my answer is, I don't know. Because there are many, many different interpretations of posterior tongue tie, and nobody is quite able to come to a consensus on it due to the anatomy. So when we look at the anatomy of the tongue, that posterior tongue, that space that's coming down but inferior to the forum caesum and the epiglottis, that is supposed to be tethered. Tethered meaning attached. If this is not attached, our tongue, we are going to completely lose stability. And it can fall into the airway or lose complete control of being able to function. So I think oftentimes posterior tongue tie is a term that is used when there's no visible tongue tie, but there's still poor function. And the question is it really a posterior tongue tie or could it be something else? Could it be function? Could it be tone related? Could it be control, range of motion, speed of movement, all kinds of those salient features of movement that we need to think about? So something that definitely needs to be looked into further, but we don't have time for that today. So when we think about assessing tethered oral tissues, there are a few common assessments, and I've listed a couple of them here. We'll talk about them a little bit. Um, the existing assessments that we do have are really lacking in psychometric data that give us the ability to feel like they're very reliable and valid. They don't have a lot of strong data, but as of right now, they are what we have. They're typically used by lactation consultants or SLPs that are trained. Not to say other people can't use them, but you really do need to have some additional training to get into that and really know what tissues you're looking at. In a severe form of ankyloglossia, it's really visibly apparent. You may see a heart-shaped tongue, that bowing of the tongue. You see restricted movement, inability to latch, inability to move a bolus around, things like that. It's more in the mild to moderate ankyloglossia where the confusion arises. The real obvious ones are just that, real obvious. And as we're going through this presentation, I just disclaimer, I'm not saying that it's not something that exists, and I'm not saying that no child should ever have their tongue clipped. I am saying we need to be very, very cautious about it and that it is likely being overdiagnosed and overtreated at this time. Um, so the diagnosis should not only rely on these grading scales, but also on that functional assessment. So somebody may have a short lingual frenulum, but if they can get all the functional movement, they have the range of motion and the strength and mobility they need for speech production and feeding and swallowing, then we shouldn't be addressing or shouldn't be doing any kind of surgical management with it. So a brief visual inspection is really inadequate for diagnosis. You really need to have a much more in-depth look at how that child's tongue is functioning with the tissues that they have. Um, the current understanding of ankyloglossia and its impact on breastfeeding really necessitates that we look at the anatomical and the function, not just one or the other. And best practice really should include both those things. So looking at the first scale, the Coriolis ankyloglossia grading scale basically breaks up into a classification system that has 4 types of lingual frenulums based on the point of attachment and the most widely used definition. So I have some images here that look at those. So here, this is a type 1, which is where we have the insertion of the frenulum really a little further anterior. The type 2 is the insertion is slightly behind the tip of the tongue versus being all the way at the tip of the tongue on that anterior surface. And you can see that if there's a child whose frenulum is this tight, that is likely going to impact possibly their ability to get full mobility, possibly lateral movement. Though, depending on the length and the tone of their tongue, it doesn't necessarily mean it's going to restrict their ability to get full range for tongue cupping, because the tongue cupping is the lateral surfaces coming up, which is what we need for suction, or for linguodental or linguoalveolar phonemes. So you can see in this image, that is a tight lingual frenulum, but we already see some cupping here. So it's possible that even though it's a type 1, it may be functional, it may not be. Type 2 has that, like I said, a little bit about 2 to 4 millimeters behind the tongue tip. In the type 3, we have a thickened attachment to the mid-tongue and the middle of the floor of the mouth. Usually it's tighter and a little less elastic. And then we get to type 4, where it's a very inelastic submucosal frenulum, and it may restrict movement of the tongue here, where you almost can't see that there's one there. But it's much tighter, and so it's going to possibly restrict movement. But again, these all need to be paired with looking at function. The Hasselbacher is an assessment tool that does include some more of the function. It's a 12-item scale with points for frenulum appearance, as well as points for the tongue function. So a score of 24 has normal function and normal anatomy. According to the scale, the frenotomy is necessary for symptomatic only in its appearance score. So we don't want someone getting their tongue clipped if it's just an appearance issue, but if its appearance is less than an 8 or the function score is less than 11. So I can't stress that enough. We really need to focus on function. So for perfect function scores, regardless of appearance, we should not be messing with the anatomy at all. And so a frenotomy would not be recommended. This is probably the best of the 3. However, it's very time intensive, so it is not one that is often used. The Bristol was developed to incorporate much of the benefits of the Hasselbeck Baker, but to make it a little more portable and teachable. It's really only a scale of 4 to grade tongue tip appearance, alveolar attachment, and tongue lift, as well as tongue protrusion. So it's looking more specifically just at function rather than appearance. We've got tongue tip appearance, this first part, but again, you can have a heart-shaped tongue and fully normal function. So being able to look at all of these components together. Protrusion of the tongue in order to lateralize, cup the tongue, and protrude to the teeth, between the teeth or the alveolar ridge is really what we need for speech and feeding. So what about function? As I said, we can have a tight lingual frenulum and still have a decent suck. This is a really good image of that. So this is really a type 1 tongue tie where you can see it's right at the tongue tip. However, you can't see that this baby is getting pretty good tongue cupping. So there may or may not be difficulties with latching at bottle or at breast. That's something we need to look at to see. And if they are having issues with latching, is it really the tongue function this way, or is it function in terms of them learning how to suck, how to extract, how to change the pressure in the oral cavity? We do see more issues with tongue tie in terms of prolonged sore nipples in moms who are breastfeeding. That latching difficulty may or may not be related to the tongue. We've all seen lots of babies that have difficulty latching, but have a completely normal anatomy of their tongue. So looking here, these are some of the most common signs and the symptoms associated anecdotally with ankyloglossia. So for the mother, it's really oftentimes most about pain and comfort. Breast engorgement, blocked ducts, creased or blanched nipples, bruising, mastitis, all of these kinds of things can really be an issue when the baby has a tight lingual frenulum. As we look at the issues that are the more common signs and symptoms associated, anecdotally, we have biting or grinding, the baby having clicking noises, colicky symptoms, difficulty with swallowing, falling asleep, difficulty with latching, all of these symptoms. So I'm going to ask you to just take a look at this list, especially on the newborn side, and see what other things could have these types of symptoms besides a tongue tie? And I'll just take a second to see. So what other issues could result in these types of symptoms? Prematurity, absolutely. Reflux, yes. Respiratory involvement, absolutely. Airway, overall tone of the child, can't stress that enough. We need to be looking at their tone, their overall tone as well as their orofacial tone. Yeah, so all of these things could also be explained by other pieces of our assessment. So it's really important that we are looking into that and need to think about all the possibilities in our differential diagnosis before we say this baby's not latching well, we need to get they need to get their tongue clipped. And I think if we're looking at this from a more functional standpoint, trying all of the other tricks in our bag before we go right to clipping will be doing the babies a little bit more of a service. Just a brief overview as far as surgical management. There's different types. There's a frenotomy, a frenectomy, and frenuloplasty. So I'm not going to get into those, but these are all terms that are thrown around. Essentially, they all mean clipping. It's just a matter of how they're doing the clipping, how the surgeons are doing that. So The American Academy of Otolaryngology had a neck surgery attempted to come up with a clinical practice guideline related to tongue tie. However, they could not find enough quality evidence for that clinical practice guideline, so they came out with a clinical consensus statement, which doesn't actually have a lot of consensus. So the panel did acknowledge and validated that an anterior tongue tie is oftentimes impactful on breastfeeding, specifically on the maternal pain. Many of the other symptoms that we see that we saw on that list can be explained by other issues. But that the maternal pain and discomfort can oftentimes be explained by that tongue tie. However, frenotomy or frenectomy is not always effective in relieving that maternal pain. So their consensus was essentially there is no consensus because it doesn't always help. They also could not reach any kind of consensus on posterior tongue tie, what it is, how to describe it, how to assess it, or if it even exists. There's broad debate about that. And the one thing that they did agree on, though, is that a frenectomy is not appropriate to prevent future speech issues or future speech disorders. There is enough evidence to show that surgical intervention does not prevent or avoid speech sound disorders later in life, as I see here. So generally speaking, in 2020, Selt and colleagues did a study of 59 children, and they put them into 3 groups: treated tongue tie, untreated tongue tie, and no tongue tie. Measured their lingual frenulum structure, function, and tongue mobility, as well as speech production, and parent and clinician intelligibility ratings were collected. And what they found was that there is no difference between tongue mobility and speech outcomes in young children with or without intervention for tongue tie during infancy. They also found that there was no statistical significant difference between the groups of treated tongue tie, untreated, or no tongue tie for tongue mobility across the board, speech production, or intelligibility ratings. There is evidence, as we've talked about before, that that it is more common in males. However, this is just another study that demonstrated that there's no evidence that ankyloglossia or tongue tie causes speech disorders. The biggest impact that it does have is on maternal comfort during breastfeeding. This study showed that all subjects with a frenulum of less than 1.5 centimeters had rapid and adequate tongue mobility. So it's leading us into the direction of finding a very objective measure of tongue mobility. These were actually replicated results from a study done in the 90s, which showed that less than 1.6 centimeters is normal free range movement. There have been some other studies also that have looked at this, and that tongue mobility should only be addressed when that lingual frenulum is less than 0.7 centimeters. A lingual frenulum of greater than 0.7 centimeters typically results in appropriate functional movement for sucking, swallowing, and speech production. So in conclusion, we really have no good consensus across professions. There's no clear evidence to support posterior tongue tie or what to do about it. Surgical treatment of anterior tongue tie may decrease maternal pain during breastfeeding, but that's not consistent either. There is inconsistent evidence that surgical intervention improves infant sucking because there could be many other issues that are causing that infant to have trouble with their suck. The infant suck itself is soothing and calming. So some anecdotal evidence is out there that, well, right after the clipping, they sucked better. They had a better suck. They latched onto a pacifier. They were doing well. Well, what we know from a neurological standpoint is that the suck is soothing and comforting. So when a baby has a procedure that may involve some pain, the suck is calming and soothing them. So could that possibly be the reason for that immediate improvement in suck after the procedure, because there's no consistent evidence to show that there's a long-term effect in terms of the rate and increase of sucking like is seen directly after the procedure. So generally speaking, surgical management should not be implemented to prevent a possible future speech sound disorder. We should really be looking at this in terms of function, function, function. And the biggest outcome is that we don't know enough. We need more evidence, we need more inquiry, and need to dive into this more. So I guess with that, I'll open it up for if anybody has questions, and I have my references here.
Thank you so much, Cindy. I just wanted to pause a minute to say thank you for sharing this. And we will be sharing the recording and your references with the group. We're going to stop the recording now so that we can open it up to questions